non-specific, bone marrow aspiration normal. This is the rash. What is the diagnosis, Dr. Anu?
Like I said in the previous case, neutrophilic leukocytosis, thrombocytosis, high CRP, rash, hepatosplenomegaly, and your marrows are pretty normal. So my only diagnosis would be systemic onset JIA, and of course the differential, the question which sir has written, there is no arthritis. So that can be there, sir. The current SOGIA criteria, which involves presence of arthritis, is not actually 100% sensitive. So it will miss around 30% of systemic onset GIA if we are very headstrong and we try and get only arthritis. So there can be systemic onset GIA without any musculoskeletal symptoms. So in this child, I would keep SOGIA as my diagnosis, but rule out other which has already
Sometimes,
been done.
sometimes I, as a general pediatrician, think SOGIA or a systemic inflammatory syndrome where there is a biochemical evidence and a prolonged fever without musculoskeletal. SOGIA or a GIA is a dumping diagnosis. Nobody can prove, nobody can disprove.
Sir, it's not actually a dumping diagnosis because you have beautifully worked up the case. You've done a marrow, you've done brucella, you've ruled out tuberculosis. It's not a dumping diagnosis, it's a diagnosis of exclusion. So if you've ruled out your tropical infections, and then I don't think it's a dustbin diagnosis. I think
No,
it's a
no,
pretty.
in the absence of musculoskeletal.
Yes, sir. We,
Okay.
in fact, in our clinic also, if we analyze the data, which we did previously, around 15% of our systemic onset JIA did not have arthritis at presentation. But later on, they would develop arthritis. They may or may not.
Okay.
Dr. Bagdi has.
So I will come to Narendra. So let me just go through.
Ji, sir.
So the question for Narendra is now repeated and thorough examination, lack of infectious markers, whatever, and these important clinical clues, some of which were there in our patient. Now question is we investigate inflammatory markers. Narendra ji, there are many immunological markers which are done for all these rheumatological disorders suspected. ANA, rheumatoid factor, anti-CCP, HLA-B27, vasculitis panel. So in a private hospital, they cost some around 30,000 rupees. The utility of these in GIAs.
So the short answer is none of that is required for the diagnosis that the index case is concerned. And for investigating these disorders, the pretest probability should be very high. Now coming to the systemic onset GIA, it's a diagnosis of exclusion, and I really appreciate the fact that you have considered a marrow in this particular child, because systemic onset GIA is a diagnosis of exclusion, and at times it's very important to rule out malignancy like we have done in this particular case. So that's one. Number two, coming to the role of these particular antibodies in GIA. ANA is considered for GIA, there is a subtype of GIA which is known as oligoarticular GIA, and the kids who are ANA positive are likely to have uveitis. By that, the clinical implication is that they need to be screened more frequently for uveitis. Coming to rheumatoid factor and anti-CCP, only 5% of the all subset of GIA will be rheumatoid factor or RF positive GIA, and they usually resemble that what we call rheumatoid arthritis in adults with a more aggressive disease. HLA-B27 is positive in around 80% of the patients with ERA, and this is the subtype of GIA which is most prominent or which is the most common subtype of GIA in this part of the world. I mean, in Southeast Asia, ERA is the most common subtype.
So do I take a message that when there is a SOGIA or a JIA without any musculoskeletal symptoms, these antibodies may not be done?
Yes, may not be done. Rather,
Okay.
systemic onset GIE is an autoinflammatory condition. And if there are autoantibodies positive, I would keep that possibility of systemic GIE doubtful.
Okay. And as far as bone marrow, most of us as general pediatricians are convinced if you think of SOGIA or any GIA, before starting any steroids or immunosuppressants, a bone marrow must be done.
Yes.
So you agree with me there. Okay, we move on to a third case. 15-year-old girl, well built, smart girl, various antibiotics for fever for 1 month. Low grade, sometimes high, no specific pattern. There were several lymph nodes in the neck, and I know you will be seeing a scar in the neck. You know what diagnosis did I get. So travel trip, again infection markers all negative, very extensively investigated, except for EB virus positive, VCA. Otherwise, all infection workups negative, non-specific lymph nodes across various systems, abdomen, neck, and again these immune markers were negative. Echo normal, bone marrow normal. Question was what next? This is what the usual protocol is. Again, coming to what I unfortunately said dumping diagnosis because there's no way to prove or disprove. So this is a list. Uh, any differentiations or any particular diagnosis in this girl? Dr. Anshu, Anu Singh ji.
Sir, like you have rightly mentioned, in such a situation, adolescent girl who is coming with a prolonged fever, if you
A
ask
little
a
louder,
rheumatologist, if you ask a rheumatologist, I would say I would suspect systemic lupus erythematosus. But as under evaluation, you have showed ANA came out to be negative, which is positive in 99% of the cases. So I would keep maybe tuberculosis like infective etiology, or among the inflammatory disorder, one of the entity is Kikuchi disease, which can present like an adolescent girl with having low TLC, lymphopenia, they can be so, and lymphadenopathy. So one of the
Okay, so the
disease can
point
be
is
this
taken.
is.
We did cervical lymph node biopsy and it was Kikuchi's. I'll not go into the Kikuchi's. It is a standard textbook description. So I'll go to the last case. This is a child with prolonged fever, intractable seizures, status epilepticus, hepatosplenomegaly. All markers were suggestive of HLH. Okay, so I am giving you the diagnosis there. MRI brain had hyperintensities in subcortical white matter, including basal ganglia. Now the question was differential diagnosis. Is it ITES? ITES is a new entity in last 2-3 years where we say infection triggered encephalopathy syndrome and HLH with HLH. Now, how to differentiate in such patients clinically primary HLH or a secondary HLH? Dr. Narendra, you can take.
So I think for sure this is HLH or hemophagocytic lymphohistiocytosis. So as far as primary and secondary HLH is concerned, usually primary HLH, there are certain scores, MS scores and other scores, but for simplicity, usually the primary HLH will present early. They will have very high ferritin levels and of course have organomegaly and cytopenia. Whereas the secondary HLH or what we call as macrophage activation syndrome is often mostly associated with conditions like systemic onset GI. So here, but as far as the management is concerned, to begin with, the key is the steroids on the immunomodulation. And here I think irrespective of, we of course will send a clinical exome for primary HLH, but before that we'll start steroids in this patient.
Are there any clinical markers when in the absence of a illness which could lead to secondary HLH? Can I differentiate? I have evidence of HLH. I have prolonged fever. Infection markers negative. Can I think there are some HLH which present even in later in life?
Yeah, they can present and they
So
are,
how do I
for example,
differentiate?
there are CNS
Yeah,
manifestations like in this boy. Probably is one clue.
yeah.
Add one point here.
So
After we are over. So just 1 minute more, and I just wanted to mention or sensitize for this. Are you convinced with this term ITES? Okay. So this child could have fit in ITES probably. I do not know whether can cause HLH or not because it is only a term which is there in 1 year. And so therefore this is HLH and we proved it to be primary HLH and this was again at 7-8 years occurring later in life. So finally one question for Alok ji, you.
Sir,
As an hospital administrator, since you look after many pediatricians who would be involved with your this thing, so one message was that we should have administrators like kind of a team rather than allow our general pediatric friend to just go solo with these complicated cases. Your comments on HLH, we see as general pediatrician lot meant HLH after dengue, typhoid and TB, JIAs. So any comments on HLH as a general pediatrician's perspective?
Most of pediatrician are stuck with the infective etiology only. And even if we are talking about Sogia, Kawasaki, most of the referral we get in the hospital they are on ATTs, CRP high, ESR. They don't work up, they don't want to work up, they just start the ATTs. But of late, we are lucky, we are getting we are taking help of Dr. Millie, we are taking help of our rheumatologist. So non-infective causes, we are at least started thinking in general pediatric, first thing. And HLH is being made in secondary level hospitals also because of the ferritin and all these markers, we are getting it. And bone marrows are being done, that's all.
So thank you, and I think I will stop with this, and since the time is short, but thank you for all your summarizing messages, because we think of Kawasaki and the patient is poorer by a few thousand rupees. It is a clinical diagnosis, nobody proves or disproves it, especially when coronaries you see are normal. So it is a very high stakes battle. Number 3, never miss it, at the same time never overdiagnose, and don't miss out on Sogias, and always take help of our rheumatologist friends whenever we are faced with these cases. Thank you, and over to Chair.
It's a small few comments.
Sir, one more question. As a general pediatrician, we see all these coronary changes in second or third week. But when we